Welcome, everybody. Thank you for joining our first webinar in our new series entitled In the Middle, Managing Your Midlife Transition, which is part of our Weill Cornell Midlife Women's Program. I'm Susan Loeb-Zeitlin. I'm a gynecologist at Weill Cornell and a North American Menopause Society certified menopause provider. I've been working on creating a program for midlife women at Cornell, along with my colleague, Dr. Peggy Polineski. One of our major goals of the program is to develop educational and informative resources for our community. Today's topic is titled Your Midlife, Managing Your Weight During the Midlife Transition. And it's clear that this is a topic of interest to so many women, given the overwhelming response we received to this program. So I'm honored to welcome our amazing panelists, Dr. Katherine Saunders and Dr. Leon Igel. Just for introductions, Dr. Katherine Saunders is an assistant professor of clinical medicine at Weill Cornell Medical College. She specializes in the care of patients with obesity and weight-related medical complications. Dr. Saunders completed her residency in internal medicine at New York Presbyterian Hospital and an obesity medicine fellowship at Weill Cornell's Comprehensive Weight Control Center. Dr. Saunders is board certified in internal medicine and obesity medicine. Her clinical interests include drug-induced weight gain and medications for obesity. Dr. Saunders is also co-founder of IntelliHealth, a healthcare technology company whose mission is to scale and democratize access to effective obesity treatment. IntelliHealth's online weight program, Evolve, which is integrated into the electronic health record at New York Presbyterian and many other health systems, is designed to give providers and patients everything they need to treat obesity successfully. Dr. Leon Igel is an assistant professor of clinical medicine and attending endocrinologist at Weill Cornell Medical College. He is director of the West Side Division of the Comprehensive Weight Control Center and program director for Weill Cornell's Obesity Medicine and Obesity Medicine Bariatric Endoscopy Fellowships. Dr. Igel specializes in the care of patients with obesity and obesity-associated endocrine conditions. Dr. Igel completed his residency in internal medicine at New York Presbyterian Hospital, Weill Cornell, and subsequently completed a combined endocrinology, diabetes, and metabolism fellowship at New York Presbyterian Hospital, Weill Cornell, Memorial Sloan Kettering Cancer Center, and the Hospital for Special Surgery. Dr. Igel is board certified in internal medicine, obesity medicine, and endocrinology, diabetes, and metabolism. If we could give him an applause, we would, but welcome both of you. Dr. Saunders, why don't you tell us just a little bit more about yourself and about your practice?
Sure, Sue, thank you so much for having us here. We're really excited to be part of this panel. Oh, and I apologize, there's a train going by in the background, so not great timing, just try to ignore it. As Sue mentioned, my specialty is obesity medicine, and I would say the majority of the patients we treat are women, and the majority of those women are over the age of 40. So most of our patients are very similar to the audience here today. Most patients, by the time they come to see us at the weight center, have tried so many different ways of losing weight, so many different diets, so many different strategies, and then they come to see us when they have a friend or a family member who is a patient of ours who's been successful, or their provider refers them to us. So by the time we see patients, they're extremely frustrated because nothing has worked. And so what we do in our practice is we do a really comprehensive initial evaluation. We look at a series of labs, we ask many questions, and the purpose is really to figure out all of the factors leading to weight gain, all of the barriers preventing weight loss, and to come up with a very personalized plan for each patient. Weight regulation is extremely complex. It's so much more than just calories in, calories out. So obviously strategies like eat less and exercise more are really not sufficient for most people. So the cornerstone of what we do is lifestyle modifications, but our specialty is really treating those people for whom lifestyle modifications have not been sufficient. And then we're able to use advanced strategies, which I'll let Leon get into a little bit more. And then we'll have a lot of time for questions. So thank you again for having us. We're looking forward to a great panel.
Thank you so much. And we will delve into a lot of those topics more in a few minutes. But Leon or Dr. Igel, go ahead. Tell us more about you and your practice.
Again, thank you so much for having us. So my practice is very similar to Katherine's. I am an endocrinologist and a weight management specialist. So I have a little bit more of an endocrine flavor to my practice, but nonetheless, we really practice similarly. I would say the crux of my practice, in addition to everything that Katherine mentioned, is we really focus on some of the medications that might be contributing to someone's weight gain that they may not realize are having a contribution, and also in potentially adding medications that have a weight loss promoting effect to really help the folks who have already tried so diligently to lose weight through the lifestyle approaches and have still met with trouble in that arena. So we really, over time, will sculpt a personalized regimen based on what a patient may be experiencing. And quite often, as Katherine mentioned, we're focusing on patients who are going through a midlife transition. It really is a common time for weight to start creeping up. And again, that's really where we emphasize a number of different strategies.
So that's a perfect way to start. So let me start with you, Katherine. Do you think all women going through the midlife transition gain weight? And if so, why does that happen?
Great question, Sue. Definitely not all women. I would say there are some women who are very lucky. These are probably the same women who didn't gain weight in college, who didn't gain weight with pregnancy. Most women are not that lucky, and during one of these stages, find themselves gaining weight. It's often women who may have a family history of weight struggles, or may have a family history of diabetes, or a family history of weight gain during similar periods of time. So, if you look at your mom and, she gained weight during menopause, that may be an indication that you may be gaining or have gained as well. And so it's common, it's very, very common, but no, it's not everybody. There are many different reasons for this. As we get older, our metabolic rate slows down. So that's definitely part of it, not as much, menopause specific, but just, as we get older, that happens. And there may be a bit of menopause specific slowing as well. Insulin resistance is something that can happen or can be exacerbated during midlife. And this is a period of time or a condition where we're more prone to gain weight in our abdomen. And we can talk a little bit more about insulin resistance, but I would say the slowing metabolic rate, insulin resistance, hormonal changes are definitely to blame here.
Yeah, just to follow up on that with you, I get asked this question a lot. My diet hasn't changed, my exercise hasn't changed, but why am I gaining weight?
Right. So, and that's a great point. So we know that around this period of time in menopause, you may not be consuming more calories, but with the slowing of your metabolism, the average slowing is roughly around 8% of the slowing of your metabolism. So as we know that slowing occurs, even eating the same number of calories, you have to do more to even just maintain weight. And that is really an ongoing struggle that we know our patients experience. So again, same number of calories coming in, no change to your diet, and weight insidiously starts to rise. And as we see that is where some of our strategies can be very helpful in helping patients sort of understand ways to offset that slowing of their metabolism that occurs, and that insulin resistance that Katherine mentioned that makes it even harder not to put weight on, specifically in your midline. And that's, again, a real frustration, because those body composition changes are really what end up being also frustrating when people feel that, yes, their weight is climbing, but they're also noticing changes in their distribution of their weight and in how that weight is manifesting and appearing. And again, into a less sort of healthy modality where that weight is targeting the midsection.
Right. So why is it targeting the midsection? Why does it all get deposited right there?
So that really goes to the heart of insulin resistance and a good deal of what we're describing in insulin resistance. So insulin resistance by itself, when your body becomes more resistant to your own natural insulin, you end up overstoring a number of the calories that you eat. And I often talk about insulin sort of waiting around to kind of grab the calories that are coming in and socking the calories away in your fat storage, and specifically in the midline area. And that really is where we notice the most significant weight gain. And so part of what we end up targeting are specific diets that are dedicated to improving insulin resistance. And sometimes if folks have not met with success with that, we also occasionally use medications that can improve someone's insulin sensitivity. And so we really do target that particular area when we're treating folks who are going through that midlife transition.
That's great. So I want to get into all of those things, lifestyle modifications, medication, but just for our audience, like, how do we know if we have a weight problem? Can you kind of explain BMI, what it means, how we calculated it, and how we use that to kind of define who has a weight problem and who doesn't?
Sure. So body mass index is a ratio of height versus weight. No need to understand the actual equation. If you put into Google a BMI calculator, there are tons of BMI calculators. You basically just put in your height and weight, and it'll tell you the number. It's not a great way of indicating what's going on in your body on an individual basis. It's more helpful for kind of population, looking at populations, but it basically gives us a sense of weight category. So it goes from, underweight to normal weight to overweight. And then there are 3 different classes of obesity. So class 1 obesity, class 2, and class 3. It's helpful for us as providers to know where people are starting because there are guidelines in the field of obesity medicine that sort of dictate, who's eligible for medication, who's eligible for a bariatric surgery. And it also tells us, there's really kind of a U-shaped curve when you look at chances of getting sick from your weight, weight-related health complications, or chances of dying, for weight-related reasons. And the bottom of that U-shaped curve tends to be in the normal weight range, depending on which curves you're looking at, and it increases with increasing weight. So helpful more on a population base, somewhat helpful on an individual level just to know where you are. But 2 important things to say about that. One is that it really doesn't give us an indication of body composition. And so when you look at football players, they all are in the obesity range, even though they're incredibly fit. And so for us, it really doesn't tell us the ratio of fat mass to, lean body mass. The second thing is that our goal for patients is not for all of our patients to be in a normal BMI range. If somebody starts with class 3 obesity and they lose 3 to 5% of their body weight, which is really, or maybe 5 to 10% of their body weight, which is, when you look at data, what is necessary to see major improvements in a variety of weight-related health complications, they're not necessarily going to get down to a normal weight, and that's okay. Their weight-related medical problems may improve, their labs might look much, much better. So a lot of people have this idea that they need to be in the normal range, and that's definitely not our goal.
Yeah, that's a great point. Losing 5 to 10% of your body weight is a really good, at least, goal to get started, right? But is there a different measure that you prefer to BMI, or is that really the one that you'll use?
So there are a number of different ways that we can analyze body composition more than looking at weight. So some of the ones that we see more frequently these days can be bioimpedance assessments, and actually a number of scales now have those bioimpedance features built in that will give us a better breakdown of someone's fat composition versus muscle composition versus water composition. And up the ladder, there are more sort of scientific measures that we'll use that we don't use quite as frequently, but in our weight center, we have a number of ways to assess that more directly on scales and sort of higher end machines that will give us those sorts of readings. But in general, we do use even though BMI doesn't speak to body composition quite as well as we'd like, we do still use it as an individual screen because it still gives us a sense of where someone might be starting. I think the frustration can be that menopause is a time where, again, that muscle versus fat mass sort of change can occur, and that sometimes even when weight isn't changing significantly, composition is changing significantly, and or distribution of that weight changes. So it may not always speak to the problem that someone is experiencing, but we still, as providers, certainly hear that and will address it more directly when talking to an individual patient. If they're saying, hey, my weight hasn't really changed, but I'm noticing just this extra storage that's now occurring between here and here, and it's really a big change for me in the last 2 years.
I mean, I think that's a great point, and that's sort of how we manage our menopausal patients too. Everybody is individualized, so you can't just use one number and one treatment. It's there's so many different ways to do this. So I think that's a really important point for managing all of our patients. All right, so let's get to the meat of this. So let's start with lifestyle modifications that we can use to control our weight, especially during this midlife transition.
So the cornerstone of everything we do is really lifestyle modifications, and that spans from, dietary strategies to exercise to different behavioral techniques. We've been talking a lot about insulin resistance. I would say we generally recommend dietary strategies that are along the lines of low carb or low glycemic index, which are best for insulin resistance, or among the better ways of eating for insulin resistance. The main thing about diet, though, is that there's no, one size fits all approach here. And we never want people to feel like they're on a diet. So the key is to figure out a way of eating that doesn't feel like a diet, that can be just reasonable and very sustainable for our patients. That being said, we have a couple of strategies that we find to be particularly effective and sustainable. That make it just easier to kind of reduce carbs and to focus on good quality carbs and lower glycemic index foods without feeling really deprived. One of those is starting the day with a high protein breakfast and trying to be very careful about eating carbs in the morning, because there's studies that show that if you start your day with carbs, you're going to think about food more, eat more all day long. Whereas if you start your day with protein, you tend to have a more, balanced day. Another strategy, this is actually an area that our center is well known for. We've done several studies looking at what we call food order or macronutrient sequencing. And this basically is, if you think about going to a restaurant and eating the bread basket, that's not what we want to be doing. So what we do for these studies is we have the same group of people come in on 2 different days and eat the same meal, but in opposite order. The first day they come in and basically have the bread basket, and then they wait 10-15 minutes and have protein and vegetables. The second day they come in and they do the opposite. They start with protein, vegetables, they wait, and then they have their bread at the end. And we take a look at their blood sugar and their different hormones that tell us how full they are, how much, how hungry they are. We look at all of those hormones for the next few hours. And what we see is that on the day when they have the carbs first, we see their blood sugar goes very high. So think about kids having the sugar high. What happens after sugar high? You crash. And when you crash, you get tired, more hungry, think about food more, versus literally eating the same meal, but having the carbs or anything even remotely starchy that you're eating at the end of the meal. That can be really powerful, because what we see is that blood sugar is much more level. So it sounds simple and it sounds silly, but just by trying to have some protein and protein vegetables before carbs or before anything that you're eating that's starchy, that can actually make a difference. And then you don't have to feel like you're depriving yourself and trying to never have carbs. So those are 2 strategies that we're particularly big on. I've just talked a lot, so I'll pass it over to Leon.
That's great. So we should teach restaurants to give nuts and carrots and then serve bread at the end, right?
Exactly.
The restaurants know what they're doing. And if it was going to make you less hungry, they wouldn't put the bread on the table, right? It really is an intelligent modality, because they recognize that starting your meal with carbohydrate actually spikes your glucose. It makes you hungrier. It's not something that you actually fill up on. The items that contain protein and fat are often what offer the real sense of fullness. And so starting that way is much better for that sense of satiety that you have from a meal. And again, you'll have less of a spike in your glucose, as Dr. Saunders mentioned. And when you have a glucose spike, your body has to respond to that glucose spike by using insulin to lower your glucose. And again, how insulin works, its job is to grab that sugar that's in your bloodstream and take it out of your bloodstream and sock it away in fat storage. So again, the less of a blood sugar spike that you're having, the better off you are in terms of that hyper storage mechanism that occurs with insulin. So we have seen a significant difference in terms of patients who have diabetes, pre-diabetes with those same food order and macronutrient sequencing order studies. So really quite something to be able to change. And it's usually not a difficult change for people to make, because you're not asking them to change the diet itself. And I should say your nutrition itself. We try not to use as much of the word diet, because diet is something that's somewhat temporary or seems like something that you might stop, versus just good nutrition is good nutrition. And with not having to actually change the food itself, but just change the order you're eating it in, that can really be quite palatable to someone, instead of in totally removing all carbohydrates from the diet.
Great. So you spoke about what to eat, Katherine, in the morning, right? I have an attendee who asked this great question. The toughest time of day is like from 3 to 7:30. And she says that carrots and hummus just don't cut it. What do you recommend that time of day? What's a good thing so that you're not just peaking out at the end of the day when you're tired and hungry?
Sure. We have many patients who have trouble around that time of day. A lot of people, several patients I saw this morning actually were telling me that they're just so busy at work that they're skipping lunch or really not paying attention to their lunch choices very much. So looking at what you're eating for lunch is a good first step. If you know you're eating a lot of carbs for lunch, that can cause the blood sugar spike and then the crash that makes you more hungry exactly at that time. So thinking about planning ahead so that you're not starving at lunch and then you grab something that's not great. Or if you have no time, having a protein shake or a protein bar, but really trying to maximize protein and not have so many carbs or have carbs at the end during lunchtime can dramatically affect the next few hours. Or proactively, I have another patient I saw today actually who exactly at 3:30 every single day, she knows that's her problem time. So she always has like an apple and peanut butter or, some kind of high protein snack at that time every day.
Great, thanks. So there's some questions coming in. Our conversation today, Leon, is about women of all different body shapes and body sizes. I just want you to clarify, is this relevant to everybody, not just women who are obese? And is this relevant, our conversation, to women, all women going through the menopause transition?
It is. And again, composition and some amount of weight gain is common, even if you were starting at an entirely normal weight prior to menopause. A small amount of weight gain at the very least is incredibly common. I think the stats are that 90% of women will experience some amount of weight gain in that midlife transition timeframe. So you don't have to have, from a dietary perspective, the changes that we're talking about can be very helpful no matter where you're starting to offset what occurs in that timeframe.
Yeah, that's great. I mean, I have some really skinny women who gained 3 pounds during the transition, and that's really troubling for them. And so some of these strategies really can help them for sure. Thanks. All right, so let's talk about, there's a lot of diets out there, we know, right? So a lot of questions are coming in about intermittent fasting, and there's keto diets. So what diets do you guys recommend? And Weight Watchers even, is that something you recommend? And are they helpful? And what works?
Yeah, so really it's about the best diet is the diet that doesn't feel like a diet. So that's going to be different for everybody. If you look at, there was one classic study that was published in JAMA years ago looking at 5 different diets. And what they found was that with each diet, some people lose a tremendous amount of weight, some people lose a little bit of weight, and some people even gain weight. So when you look at the average numbers, they're all basically the same. But when they asked each person to rank the diet based on how easy or hard it was for them to adhere to, that's where they really saw a big correlation. So it's kind of obvious, but the best way of eating is something that you can adhere to. And so it can't be overly restrictive, it can't be something that you don't enjoy. And sometimes it really takes, maybe meeting with a dietitian once or twice to really listen to what you're saying about what you like and what you don't like, to help you figure out how to personalize something that you actually enjoy doing and that you can stick with longer term. That being said, I know there are questions about intermittent fasting, keto. These are all really popular right now. Some of our patients do extremely well on keto. It's not something that we generally recommend as first line, dietary advice, just because it can be very, very, very hard to follow. So many people do it for a little while and then they stop. And that's a problem, because anything you're going to stop is not worth doing at all, because you're going to regain the weight and then be in a worse place than when you started. So I would definitely not recommend doing anything that's overly restrictive. Intermittent fasting is something interesting. There, different data, different kind of results looking at different data works well for some people, not for other people. So many different ways of doing it. So very, very heterogeneous data. But again, we have some patients for whom they swear by it. And some patients, it doesn't make a difference. For intermittent fasting, I do find that it really, if someone's doing like a time restricted eating type of plan where they eat, within an 8-hour window or something like that, what I find to be particularly effective can be shifting that 8-hour window a little bit earlier and stopping eating as early as possible. Even if it's not every day, the earlier you can stop eating or the smaller your dinner, that can be very effective. So many people don't eat most of the day because we're all so busy and we run around, and then you get home and you want to, kind of reward yourself with a big dinner, and that's, time to socialize. But the more people can kind of shift calories earlier, have a big breakfast, a big lunch, a small early dinner, that can work very nicely.
That's interesting. And a protein rich breakfast that keeps you going for the day, right? Is that
yes. And I think within intermittent fasting, I do also find that some of my my patients, as Katherine mentioned, will have a hard time with that time restricted eating pattern if they are typically breakfast people and they're trying to wait until 11 or noon or something in that timeline to eat, and they're ravenous, and then make a bad lunch decision because they were so hungry. So sometimes that's not an ideal setup. If you happen to be someone who doesn't wake up hungry and you're not hungry until a little bit later, that can be a very good plan. I think for folks who wake up really just overwhelmingly hungry and may make a bad decision for a lunch food choice because they tried to wait as long as possible, that's sometimes where it can undo itself. And so it's not for everyone, but in the right population, we've seen good outcomes with it. So, I think you have to sort of understand, and that's a large part of what we do with patients, is figuring out, sort of individualizing what kinds of eating patterns someone is demonstrating, when they're hungriest, when they're really sort of feeling cravings, when they're having trouble controlling eating behaviors, to adjust their dietary strategies to best suit their particular needs.
Yeah, there are a lot of individualized questions coming in the Q&A, sort of how to eat protein if you're a vegetarian, how to, like, are you okay with sandwiches because they're carbs but they have protein on them? Any comments about those questions? Yeah.
It can be hard to find enough sources of protein if you're vegetarian. So those are the people that I always suggest see a dietitian. It can be tough. That is hard. In terms of specific suggestions, there's so many, protein alternatives, and it's a little bit controversial, these sort of meat alternatives. But even a lot of vegetables have protein, so it is very, very doable, but definitely much more challenging.
And while you're at it, Katherine, because I know you have little kids, we both do, but what's a quick protein meal for moms? High protein meal for moms that's quick and easy.
If you're really on the go, I think some protein shakes or protein bars can be really helpful, or cheese, nuts, things like that can be easy to carry around.
Great. Leon, we didn't really talk about keto diet. What's your feeling about that?
So again, I think keto can be a hard diet to continue long term because eventually you'll fall out of ketosis, and the threshold that you have to sort of limit your carbohydrate intake to can be very hard to keep it that low consistently. There are just days where inevitably you'll sort of go above that threshold and not be in ketosis. So it can be a difficult diet to follow long term. And some of the dietary pieces just don't seem like quality nutrition strategies, like adding fat to someone's morning coffee and some of the other things that people do as part of that diet just aren't things that we tend to recommend, even though I can understand how you are raising your fat intake to sort of enhance ketosis. But there are versions of keto that we can get behind that, again, we speak to our patients about, that they are low carb, but not quite as overwhelming in their fat content, that sort of meet in that middle ground as being a healthier version of it and slightly more sustainable version of it. So again, that's part of what we work very closely with our patients to go through, because the true keto diet itself can be a hard long-term one to follow.
Because correct me if I'm wrong, but as we go through the menopause transition, we see a lot of women get elevated cholesterol levels, right? And so this, again, as you said, individualized, it might not be right for every woman who's going through her midlife transition. Yeah. So speaking menopause, because this is sort of a midlife discussion, what does weight loss do for our menopausal symptoms? Our hot flashes, our sleep, our mood even? What do these diets and weight loss strategies do for our menopausal patients who are going through symptomatic changes?
Katherine, you or me first?
Go ahead.
So weight loss can impact a number of the symptoms that someone is experiencing during menopause. So we do see reduction in hot flashes with weight loss directly. And again, mood and some of the other items can also improve. I think, everyone is very unique in how they experience this midlife transition, because some people are having a very significant impact of hot flashes being the primary issue. Some people experience insomnia. Some people are experiencing low libido. Others are experiencing more mood changes. And so again, it's really individualizing a treatment strategy around what is primarily impacting the quality of life of the patient in that particular time frame. So weight loss generally is helpful from all of those areas, but it's really fine-tuning what is the sort of focus of the particular patient's concerns to best adapt a full treatment plan.
Mm-hmm. I think weight loss in general just helps people feel better a lot of the time. When you look at joints, every pound we lose is 4 pounds that weight-bearing joints see. So it can be really profound. If you lose 25 pounds, that's 100 pounds off your knees or your hips, and you can prevent a joint replacement. We also have so many people we see who don't even realize, how much food or not real food is kind of creeping into their diets, because there's just so much packaged processed food everywhere. And even when people feel like they have a very good balanced diet, they may be eating things that are making them feel really terrible. And so that is kind of a nice byproduct of what we do. Oftentimes people will come back for their second visit and just say, oh my God, it's not even just the weight loss. I feel so much better. And some of that's dietary. Sometimes just with the weight loss, it can reduce inflammation, and that can make people feel better in a variety of ways. So many different things going on here.
I want to talk a little bit more about that inflammation, what you mean by that. Katherine?
Sure. So, it's really sort of non-specific, or it is also specific. It's hard to measure inflammation in some ways and hard to know where it's coming from. So, for example, when we first see people, one of the labs that we like to look at is something called a high sensitivity CRP, and it's supposed to be a marker of cardiovascular risk. But among our patients, we often see that it's elevated, or it can be extremely elevated. And so what it's picking up is really sort of non-specific inflammation. And so we wouldn't call a cardiologist if we see a very high number. We would look at it as a baseline. And then once somebody's lost a significant amount of weight, then we would check it again. And if it's come down nicely, then we would say, great, this was probably your weight. But if it's, being kind of stubborn and we're surprised, then we may, look into where else that's coming from.
That's great. And Leon, while we're talking about sort of blood tests that you do, is there a way to check? There is a way. So can you explain how we check for insulin resistance and how a person knows if that's their problem?
Absolutely. So some of the initial screening labs that we look at when a patient will have their initial visit with us, we'll look at insulin levels, and we'll look at levels like a hemoglobin A1C, which is a marker of a sort of long-term glucose in the system. And we'll get a better sense of where someone is metabolically. We'll also look at levels, including thyroid hormone levels, which can skew upwards during menopause as well. And we see a lot more subclinical hypothyroidism during menopause as well. So we end up with a very sort of robust picture of someone's metabolic health by looking at a subset of their metabolic labs and coming in. And not everyone will have tremendously abnormal levels of insulin during this period of time, where you'll see, values totally outside the range of normal. But what we do often see is that weight that's coming on in the midline is also very representative of insulin resistance as well. So we see both sort of body composition changes that let us know that that's an issue, and also laboratory values that will tip us off as well. So those kind of come hand in hand. And a number of the ways that we impact that, as we mentioned, are both lower glycemic index diets, as well as a variety of exercises that can boost metabolism. And again, maybe I'll let Katherine speak a little bit more on the exercise topic, but that is an area that we really target during this time as well.
Just a follow-up question to that. If the insulin levels are within range, is the relative difference relevant for patients? So they used to have lower ones, and now, even though they're still in range, they're higher. Is that something that's like indicative?
Quite often, but unfortunately, we usually don't have baseline levels before they come to us from the years prior. So we don't always have a point of comparison. There are times where we do have that, where I can say, this is where you were when you were 40, and this is where you are at age 55, and I can see that difference. But again, insulin is a level that fluctuates throughout the day. And so assuming one level, again, doing it fasting, there's some relevance, but it still does fluctuate quite significantly. So it can't be the only value that we use. If we see elevated levels in fasting, however, we do know that someone has hyperinsulinemia and a significant insulin resistance that can be playing a role in their weight condition. And so we will use that as an indicator of how we might go about treating someone, both from a diet, exercise, and potentially medication standpoint, pharmacotherapeutically. Great,
thank you. So exercise, we all think we'll exercise more and we'll lose weight. Is that true? How does that work? What can you recommend?
We definitely recommend exercise. It's maybe less important for weight loss. It has less of a contribution than what you're eating, but it still is extremely important. Where it becomes even more important is for once you've lost the weight, to really keep it off. So for the phase of weight maintenance, exercise is very important, and not just walking around. Combination of both cardio, which can be walking, but also some kind of strength training or weight resistance. Weight resistance is particularly important also to work on body composition. So with those perimenopausal changes that can occur with body composition, doing weight resistance to try to build up, muscle can be very big. We also see sometimes that women who are having hot flashes will notice that when they do some kind of cardio activity or in heat, that may exacerbate their hot flashes. So something that we often recommend in this context is to do more strength training or weight resistance. Also, bone health, as we get older, we're more at risk of osteoporosis, osteopenia. And so the exercise, especially strength training, plays a big role here as well.
Great. Yeah, that's really interesting that it makes sense that the weight training and the resistance training is really important. And that's a big change that women should try to do as they're going through the midlife transition to help with the body composition. I want to get to this question because I get asked this a lot about hormone therapy, Leon. So will it help with my weight?
So unfortunately, we don't often see a dramatic change in weight with the introduction of HRT with hormone replacement therapy. Depending on the other symptoms that someone may be experiencing, such as hot flashes that are interrupting sleep and insomnia and the other things that may improve with that, there can be overall improvement or a slightly greater ease in losing weight when that's introduced, but directly, we don't see a direct weight loss when introducing replacement of estrogen and progesterone.
Yeah, so you brought up sleep because that's an important one because women come in all the time not being able to sleep. So how does sleep relate to weight and how does the weight relate to sleep?
Another great question. So we do see that when someone is sleep deprived or waking up with hot flashes and having significant insomnia, it changes a number of the underlying hormones again, specifically stress hormones like cortisol, which contribute both to storage of weight in the midline, but also a rise in other hormones like ghrelin, the hunger hormone, which goes up when we're when we're not having and receiving as much sleep as we should. So some of the eating patterns can change. I think folks who've had a bad night of sleep may notice that they're a little hungrier the next day, a little bit more irritable, but also that lack of sleep contributing to greater stress and greater levels of cortisol altogether just set someone up for, again, weight gain and specifically midline weight gain, where we're really trying to avoid that particular issue. So there are times where replacing estrogen in that circumstance, when someone is having significant hot flashes that are interrupting sleep, that can really make a difference both in the frequency of hot flashes, but also in the quality of someone's sleep.
I'll add actually two more things about sleep. One is that we often see people taking over-the-counter sleep aids quite often during this period of time when sleep disturbances may start. And some of those over-the-counter sleep aids can actually make it easier to gain weight or harder to lose weight, like, for example, Benadryl or any of the PM medications. So those should be used, only as really needed. We often recommend melatonin. That's been shown to be pretty weight neutral. It's probably the best of what's out there. Nothing is perfect, but it can be better weight-wise. The other thing is I always like to bring up sleep apnea. It's something that's really, really underdiagnosed. Obstructive sleep apnea is incredibly underdiagnosed. So if anyone snores and snores heavily, and if anyone has had experiences where they wake up not breathing even for a second, or someone's told them that they wake up not breathing at night, or wake up with really bad headaches in the morning or feel really tired during the day, these are circumstances where it makes sense to see a sleep doctor or have a sleep study to see if you have obstructive sleep apnea.
That's a great point, Katherine. And again, like our initial inventory at the Weight Center will screen folks for sleep apnea. It's one of the pieces that we think is critical for overall health in folks who are carrying excess weight. So again, something to really keep in mind, that the rate of sleep apnea does increase in this time period. And so even if you didn't have sleep apnea before, we do see an increased percentage of patients experiencing that in this particular time window.
Yeah. And you screen for that with questions, do you snore? Have you been told you snore, or are there other questions that you ask?
So there's an inventory called a stop bang inventory that has a number of questions that will go into that general screening. But yes, in general, someone who's carrying excess weight, who's snoring, and who complains of daytime sleepiness, those are the usual first line indicators of concern that we may want to have someone screened with a sleep study. If someone has a partner that notices that someone has, in fact, pauses in their breathing during sleep, that's a more overt sign, but not everyone has someone in the household who can tell them that that is occurring. And not everyone is always sort of aware of that happening. You can have sleep apnea where you're not overtly having as many pauses and you're actually getting a poor quality of sleep, a less restful and less deep sleep, because you're waking yourself up to restart the normal breathing cycle that you would have. So you're not seeing it quite as overtly, but you are seeing the sort of impact on your overall health and sort of daytime energy because of it.
Great. So as we might know, the average age of menopause is about 51 and a half. It can range from 40 up to maybe 58 or so, but average is about 51 and a half. And leading up to that comes perimenopause, a time periods of a lot of hormonal fluctuations, often marked by irregular menstrual cycles and other symptoms. But is there something women can do, sort of, if they start noticing changes, to kind of prevent these things that we've been talking about sort of early on in this perimenopausal time period?
Absolutely. I would say, think about what you're eating. You don't need to go on a diet, but I would, try to cut out, low-hanging fruit, anything that's, added sugar, artificial sweetener in what you're drinking, anything that's packaged, processed, food like that, and really try to eat a lot of protein and vegetables. If you're very sedentary, any kind of exercise is very helpful. It doesn't have to be structured exercise, but just the more you can move your body. We've found that during the pandemic, our patients who fared the best have been patients generally who have not been sedentary. And that's really hard right now, where we're all stuck behind our cameras on Zooms all the time. So I think just starting with, eating well and exercising and, trying to focus on getting good sleep and stress and all of these things. I mean, it sounds kind of obvious, but that's probably one of the best things to do if you sense something like this starting to happen.
And next line, I think, would be to consider meeting with a dietitian to sort of better evaluate what some people feel they have a perfect diet, and then they recognize later that there's some areas that can be tweaked or could be adjusted without it being particularly difficult. And then at a later point, if you've really done all of those things well and you're still struggling, that's where folks like ourselves, at the Weight Center can be helpful in helping people on that journey. So, it's sort of a multi-pronged approach, and it depends on where you're starting and how much of a weight struggle you're having. But myself and my colleagues, we're here for exactly that purpose. So anything we can do to help as well.
So I think you're referring to, if this diet, exercise, lifestyle modifications don't work, you might talk about medications, right? We don't have that much time left, but Katherine, can you talk a little bit about what you do with medications and how they work?
Sure, absolutely. So those are the typical people we see, and I actually see a couple of my patients as participants here. So hi to all of my patients. The typical patients we see are people who have tried and failed many different ways of losing weight. And so at that point, based on BMI criteria, really it's generally a body mass index of 30 or above, or 27 and above, as long as they have at least one weight-related health condition. And so for patients like that, the idea of thinking thinking about sort of medical management of weight is really the standard of care according to guidelines. Just like any other chronic health condition like high blood pressure, high cholesterol, if you try a low salt diet or a low fat diet to try to bring your numbers down and it's not working, at a certain point, that's when you think about a blood pressure medication or a cholesterol medication. So same exact thing with weight regulation. Before we would think about adding a medication, we always look at people's medication lists. And if someone is taking a sleep aid that we know is particularly weight promoting, or if someone's taking another medication that we know can be associated with weight gain, we will address this before adding anything else. We would always coordinate with their prescribing provider to see if we could change to an alternative, if there are alternatives available that would be more weight neutral or even weight loss promoting. If there are no alternatives, figuring out, do you need to be on this dose, and could we get away with a slightly lower dose, or things like that. But always, always, always don't make any medication changes by yourself, and speak with your providers before thinking about any of this. But once we really optimize, lifestyle, optimized, medications, at that point, we would think about using one of the medications that we use, which can be extremely effective in combination with lifestyle for significant and sustained weight loss.
And since insulin resistance has come up a lot, some of them treat the insulin resistance. And so that's why it's really helpful for especially our women going through this midlife transition. Yeah.
Absolutely. That's really a primary focus for this time frame, is to focus on the medications that do counteract the insulin resistance that occurs in the midlife transition.
Yeah. And I know surgery is an option for some women who, really need it. You want to talk briefly about that, Leon?
Sure. So bariatric surgery, we do consider for patients who have a BMI either greater than 40 or a BMI greater than 35 with a weight-related complication. So like as an example, if your BMI is 36 and you have type 2 diabetes, that would qualify for bariatric surgery at a lower threshold. Whereas if you didn't have any weight-related complications, then they usually would not recommend surgery until your BMI was greater than 40. And there are a number of options for bariatric surgery. The most common right now is a procedure called a sleeve gastrectomy, and Roux-en-Y gastric bypass is also done fairly commonly, but the sleeve gastrectomy is really the most common right now. And again, medications in many cases can rival bariatric surgery when done under expert guidance, but there are a number of patients that we refer for bariatric surgery because that is in their best interest for what they would prefer. Some patients really don't like the idea of using medications chronically, and we fully respect that. And also the amount of weight that needs to be lost may be really quite extensive. And so we want to help patients achieve the weight that they're the weight loss that they're trying to achieve, and get to a place of greater health.
Great, thanks. We are really running out of time. So I really there's so many amazing questions coming in. So I know you're going to have a lot of interest in your program. So how do patients get into the program? And if they can't get to see you right away, what can they do? And tell us maybe a little bit about your Evolve program, also your weight management program that you have.
Sure. So people are welcome to call the Comprehensive Weight Control Center. In addition to me and Leon, we have about 7 other providers. We have wonderful, wonderful providers. Everyone is great. If it's going to take a few months to schedule an appointment, we have 2 dietitians who are also fabulous, and their wait time is a little bit shorter. So starting with a dietitian is always a very reasonable option. A little bit about the weight program. We started an online weight management platform because there's so few of us and so many people who need our help. Literally, Leanne and I are 2 of fewer than 75 obesity trained physicians in the country, and 74% of the country has either overweight or obesity. So we decided to use technology to try to bridge this gap. We're fortunate that we were able to integrate our program with the electronic health record at Cornell. So it's available to all of our patients. So one other thing about it actually is we're developing a menopause program or midlife program actually as part of our weight program as well. So we're excited to launch that program in the next few months, and it will be covering many of the topics that we discussed today. So, everything on the intersection of weight and midlife and hot flashes, sleep disturbances, everything we talked about. So we will have that in a few months.
Leon, do you want to add something?
No, I think Katherine summarized that beautifully. And again, anything that we can do to help the audience here and just more broadly is really our goal. And the hope is that the platform will extend our reach in a way that really offers other providers throughout the network the ability to use that with their patients as well, so that coming to the weight center doesn't have to be the only way that this care can be provided. And that's really a large part of the mission in scaling that access. Because we know that all of the things that Katherine mentioned, the weight changes, the sleep changes, the mood changes, the libido changes, everything that's occurring in this time period really does require expertise and an individualized approach, and weight is just one part of that. So that's a large part of how we're working with Sue here is, again, to sort of cross over in that collaboration to make sure that we're working hand in hand with all of the providers who are bridging the divide.
That was a perfect way to segue into what I was going to say. So our midlife program too, just like what you've been saying all evening, is very individualized. And we do one-on-one consults, largely by telehealth, actually, to work with our patients and at least initially to see what's going on and how we can help in a very individualized way. There's no one way to do it. And just like you guys said, that's really the main way we treat menopausal midlife women. So I know you guys are going to have a lot of interest in your program. You're amazing. I really appreciate the time you spent with us tonight. And when we're done, there's going to be a slide with resources for our viewers to kind of get information. We have a website. You guys have a website to get information and how to reach out to us. So thank you so much, everybody, for joining us. Thank you, Katherine and Leon. And look for more programs like this dealing with the menopausal issues. I know we couldn't get through everything tonight, but we will try and get more outreach as much as we can. Good night, everybody. Thank you.
Thank you for having us.